Good afternoon, everybody. My name is Deborah DeBruin, and I am Interim Director of the Center for Bioethics, and I want to welcome everybody to our Ethics Grand Rounds presentation for today. Next slide, please. Let me start with a few housekeeping items before I introduce the speakers for today. So if you have questions for the speakers, if you could please insert them or type them into the Q&A function, not the chat function. Please use the Q&A function. We'll monitor both, but it's much easier for us to manage the Q&A session if we have the questions all in the Q&A function. We prefer that you use the chat function if you have tech issues and need support with that. So if you can include those sorts of questions in the chat function, then center staff can reach out to you privately to address those issues so that you are able to view the presentation appropriately. Biomedical engineering students, if you email the email address on the slide, that is the center's main email address, to indicate your attendance, we will make sure that you get credit for participating today. And health sciences students or health profession students, if you want to get interprofessional education credit, there will be a way for you to do that we will discuss at the end of the talk. You'll be able to get a link to the appropriate processes that you need to get credit for that. We'll show you that at the end of the talk. I really want to thank our co-sponsors today. We really value the partnership of these programs in being able to bring Ethics Grand Rounds to you. Our partners for this particular event are the School of Public Health, the College of Continuing and Professional Studies, the Med School, the College of Pharmacy, and the Program in Health Disparities Research. They're fantastic partners and partner with us on a number of events through the year and certainly have been very helpful in bringing this event to you. Next slide, please. So without further ado, I'd like to introduce our speakers for today. We're very grateful to be able to host them so that they can present their research to you. So first, Dr. Laura Palombi, who's an assistant professor at the University of Minnesota College of Pharmacy in Duluth. Dr. Palombi received a BS in biology, a BA in theology, and a Master of Arts in theology from the University of St. Thomas. She received her Doctor of Pharmacy degree from the University of Minnesota in 2012, and then completed a Post-Graduate Year One Residency in Ambulatory Care through the University of Minnesota at Essentia Health in Duluth, Minnesota. Dr. Palombi completed her Master of Public Health degree in spring of 2015. She's been involved in a variety of projects and collaborations throughout northeastern Minnesota, working on substance use prevention, intervention, recovery, and harm reduction initiatives with rural and tribal communities. Presenting with Dr. Palombi today will be Catherine Dooley, who is an epidemiology MPH student at the University of Minnesota School of Public Health. Ms. Dooley received a BA in biology from Bard College in 2013. Prior to graduate school, she worked as a post-baccalaureate intramural research training fellow at the National Institutes of Health and was a health education Peace Corps volunteer in Togo, West Africa. Ms. Dooley is currently a student worker on Minnesota Department of Health's Team Diarrhea, where she assists with foodborne illness surveillance and outbreak investigations. I really want to thank both of you for being here with us today. And at this point, I'm going to turn it over to you.
Thank you so much for having us. Can everyone see our screen?
It looks great, Laura.
Excellent. Thank you. Well, it's really just a pleasure to be here. So my name is Laura, and I am really delighted to be joined by Catherine, and we'll give you just a little background. But we're going to talk today about the impact of stigma on individuals with substance use disorder and mental health conditions. And we're by no means experts in this area, but we have learned a lot through six plus years of community engaged research projects. And so we really want to share those with you because they really do shed light on some of the areas that we have to work on as a community and definitely have major bioethics implications. So before we begin, I want to acknowledge the work of many individuals who made this presentation possible and the work that we do possible. I've had some fantastic AmeriCorps Vista members, Anna Van Deelen, Amanda Hawthorne, Robin Tomaseski. We'd like to thank Recovery Alliance Duluth, who is our major partner for the project that Catherine's going to be talking about. As well as University of Minnesota CTSI, Office of Public Engagement, School of Public Health, Extension, College of Pharmacy. A lot of the projects that we'll be talking about had funding from these organizations, and so we really appreciate that, and the community does as well, because a lot of what we do is really in partnership with the community. And then lastly, the community coalitions across northeastern Minnesota, which really have made all of this possible. And those coalitions are usually led by public health, but they have fantastic people from treatment, recovery, harm reduction, and many of them are actually in this seminar right now. So thanks for joining us, community members. The coalitions really run so much of what's going on throughout our state. So we really just want to acknowledge the hard work and professionals that are involved in that. So today, we're going to talk about what we've learned about stigma. So some of the ways that stigma is serving as a barrier for accessing care for individuals with substance use and mental health conditions. We're going to look at some of the ways that this topic has emerged in evaluated community engaged partnerships. I'll be honest, when I started working in community engagement to address substance use, I didn't know that stigma was as significant of a problem as we've learned it is. And so kind of by accident, we've learned what we're sharing today. We're also going to describe how stigma varies depending on the source and the individual experiencing it, and then comparing interventions with potential to reduce substance use and mental health stigma. So I am an associate professor at the University of Minnesota and affiliate faculty at the University of Minnesota Center for Bioethics, which I appreciate. I think helped me to be able to do this presentation today, which I love sharing what we've learned. And of course, again, a member of these community coalitions that I'm talking about and public health teams that strive for substance use prevention and intervention. In this presentation, we're going to talk about a few ways that each of us can make a difference in reducing stigma and working towards more equitable Minnesota when it comes to folks with substance use disorder. And one of the things I'd recommend is if this is something that you're excited about and have energy for, that find a local coalition near you. They're all over the state because they really need more people involved. I'm going to turn it over to Catherine to introduce herself briefly.
Hi, I'm Catherine. It's an honor to be here to share this work with you today. I'm a Master of Public Health student here at the University of Minnesota, and I was introduced to Dr. Palombi because of our shared interest in community engaged research. And as an epidemiology student, I was able to help this group out with data analysis and in turn get some amazing experience working in this collaboration. Next slide, please. And today we'll be talking about stigma. So I wanted to give a definition for you. The Oxford Handbook of Stigma, Discrimination, and Health defines stigma as a distinguishing characteristic or mark whose meaning is socially conferred that both signals the recognition of a difference and devalues the person. And here I have a basic graphic of how stigma works on the level of the non-stigmatized group, this sort of plain stick figure on the top, and the stigmatized group, the stick figure who has a star representing a distinguishing characteristic. And for the non-stigmatized group, stigma is experienced as prejudice, discrimination, and stereotyping, all of which can affect outcomes like discriminatory policies or social rejection of members of the target group. And for the person who is a member of the stigmatized group, the stigma or discrimination can be experienced in a few different ways. There's anticipated stigma or the expectation of future poor treatment on the basis of having the stigmatizing condition. There's internalized stigma, which is like feelings of shame or guilt. And then there's enacted stigma, which is the perceived experience of discrimination. And through these mechanisms, you get outcomes that tend to be negative, like loss of social support, reduced access to care, and these might serve to further the stereotypes or prejudice from the non-stigmatized group. So next slide, please. And I'll hand the floor back over to Dr. Palombi.
Thank you. So this is just, we're going to briefly look at this map. Again, this is older data, but I like to show this when I do presentations in the community because I think it's very eye-opening for us to see. On the top left, you see a map of the United States in 2003, and you can see how overdose deaths, which are indicated by the red color, have progressed throughout the nation until 2014. And that was still a long time ago, right? If we looked at a map now, which we're going to look at some maps that are very dark, but I usually just like to point out that even though we feel like in Minnesota, at least I do, that substance use is such a huge burden on our communities, and I see people dying, and I just feel this heavy sense of morbidity and mortality, we actually as a state are doing a lot better than many other states and many other regions. So I just like to point this out here so you can see trends across the United States. I also have a little graph where we're not going to share too much data here. We're gonna try to talk about what we've learned. But here I have, and this is from a recent report from the Minnesota Department of Health, which is cited at the bottom. This is the number of drug overdose deaths in 2020 compared to 2017 to 2019. And we know, probably all of you have heard that the pandemic has been really terrible for people when it comes to substance use. We've seen a lot of people that were never using substances that now are. We're seeing people that were using substances and now they're using more. And we've seen people in recovery who are doing really, really well and now they're not doing well. And so you can kind of see just on this little graph how that looks. So 2020 is the top green line, and you can see the other years there going down in order: 2019, 2017, 2018. And before we get into too many more graphics and I show you pictures, I just want to acknowledge that every single one of these people, one of these numbers, so we're looking at 1,000 cumulative deaths in 2020 in Minnesota. Each one of those is a person who is loved, a family member, a son or daughter, maybe an aunt or uncle, or maybe even a parent. And so I think that's really important when we're looking at data like this to remember that these are people, valuable people that we are losing. Here's another graph. You can see drug overdose deaths by non-exclusive drug category, Minnesota residents. So you can see all opioid deaths is that line on the top. Synthetic opioids, which we know are a very significant problem right now. One thing we just like to point out, so a lot of times people think, you know, people that die of opioid overdoses are people that use just heroin, but really synthetic opioids have made it into pretty much all drugs right now. From what we're hearing, we know that synthetic opioids are put into methamphetamine and cocaine, for example. And so we're seeing a lot of people who are dying of opioid overdoses who aren't even opioid users and had no idea they were even consuming an opioid. But you can just kind of see how these deaths line up. So all opioid deaths followed, and that was in blue, followed by synthetics in orange, then psychostimulants in blue, and then we get down into other opioids in methadone, benzodiazepines, heroin, cocaine. Again, this is also on that report. Now here again, this is older data, so please forgive me, but I like to show this again when I'm doing community presentations. So you can see the 10-year difference between 2007 on the left and 2017 on the right. And this is for clients indicating IV drug use in the past 6 months within our state. And again, the numbers are even worse for 2020 and 2021. I was able to get to the most recent data. And again, these maps are from Rick Moldenhauer from Minnesota DHS. Shout out to Rick, who's fantastic at providing community members with data like this on short notice, and is a wonderful speaker as well. So here you have heroin substance use disorder admission rates, 2007 on the left, 2017 in the middle, and 2019 on the right. And you can see the colors have even changed to because of the scale. And then here is methamphetamine substance use disorder admission rates, 2007, 2017, and 2019. Now, these are just the people that are admitted. We're going to talk about how substance use disorder is one of those conditions, unfortunately, where a great number of people struggle and never receive treatment. And so these are just the few that actually got into treatment that we're looking at. So the Minnesota Department of Health, you know, when we're looking at the impact of the COVID-19 pandemic, MDH reported an increase of 27% in drug overdose deaths from 2019 to 2020. This trend shows each month in 2020 had a higher number of overdose deaths than the same month the year before. This is a critical public health emergency. It was even before the pandemic, but it certainly is now. These statistics unfortunately mirror national trends, and we do know, as I mentioned, that synthetic opioids appear to be the primary driver. And again, these overdose deaths, our numbers are never perfect. There's probably people that never made it into these statistics, and there's a lot of people who experience an overdose and thankfully had naloxone available to them and were able to survive because of that. So there's a lot of people at very high risk right now. So one of the things that we're going to talk about, so we're going to share a little bit about stigma, but after seeing all these maps and hopefully realizing the gravity of the situation, you might be wondering, you've learned about stigma, but what can I do? And what is stigma and how does it actually manifest itself? And really, what we're seeing here is stigma is a major barrier to people seeking help for substance use disorder and for those remaining in recovery. Think of that slide that Catherine showed with the stick figures. So of 23 million Americans, probably a lot more than that, who meet criteria for a substance use disorder, only 11% approximately access treatment. That is incredible. Can you imagine if only 11% of people with asthma got treatment for their asthma, or 11% of people with diabetes got treatment for their diabetes? This is, to me, it's just mind-numbing that stigma has such a huge impact on people not being able to receive care or being afraid to receive care. And there's things that we can all do. We're going to talk about that later too, but if you're wondering what can I do about this and what do they mean by stigma and how are these people experiencing stigma? The language that our culture uses right now to describe people with substance use disorder and to describe addiction or substance use disorder is one of the major reasons that people are not accessing care. And these words are very common, even in treatment circles. I was a member of the Carlton County Drug Court team for a lot of time, and we were always catching ourselves using terms like a dirty UA or dirty urine drug test versus a positive urine drug test. I worked in a pharmacy where it was very common to hear people say drug seeker, addict, and junkie versus a person with a substance use disorder. And another one that we hear is addicted babies versus neonatal abstinence syndrome. When we as a culture and as healthcare professionals and just as people, as community members use these words, we are just perpetuating the stigma that is keeping people from accessing care. So what we're going to share now is what do the individuals that we've worked with from rural and tribal Minnesota communities say about stigma. And so this is really briefly some of the projects that we've done over the last 6 years. We're going to just kind of touch on these, and then Catherine's going to focus on our major project right now with Recovery Alliance Duluth, where we're really diving a little more deeply into that issue of stigma. So we have been really fortunate to partner with a number of different communities to do community forums on opioid use and mental health. And we've done over a dozen of these now at this point. And really, whenever we do these, we always kind of use the opportunity to ask community members, what do they think? What do they think are the solutions to the opioid crisis and what needs to happen in their community? And we always hear, and this is very consistent across these forums, and we have a publication on this if you're really interested in looking further, but there is a widespread need for education on substance use disorder prevention, intervention, and recovery. We need more education. People need to understand substance use disorders as an illness rather than a moral failure. We also have a need for increased community collaboration to bridge these gaps in care. This is one of the benefits of coalitions, which I was talking about earlier. And I would say the number one piece of feedback we hear from our community members when it comes to addressing stigma and just doing better is the value in hearing individuals share their personal stories of healing and recovery. And that's at the forum. Of course, that's the number one draw for community forums. When people leave, they say those stories were just the most powerful and the most impactful. But it's not just a story at a particular event. It's allowing people to share their stories as a community and really embracing that recovery journey and hearing people out and really acting on the feedback they give us, which we're going to talk a little bit more about later. But we need to recognize that people do get better, that just because somebody has a substance use disorder doesn't mean that they should just be forgotten about or they're just a hopeless cause. There are a lot of people in recovery. And because of the stigma that comes with substance use disorders, probably a lot of us don't even know. We probably have friends in recovery and maybe they haven't even shared their story because of stigma and the fear of sharing. We also have gotten great feedback from focus groups conducted with individuals in recovery. So this was done in rural Minnesota with people in short and long-term recovery. And we did find there's a significant need for sober meetings and sober living activities was what they shared with us. And what do we say about that? So sober activities would be like being able to go to a community party and not having alcohol there if alcohol is one of your triggers. For me, this was very eye-opening. I come from northeastern Minnesota, and I started to think about this, and I realized even at kids' birthday parties in my hometown, it's very common for the adults to pull out the beer and wine because that's just what we do at our parties, and like graduation parties, and think of weddings. Think of how difficult it is if you're a person in recovery, working hard at your recovery, and then you go to try to have some social contact, which we all need, and yet there's your trigger there right in front of you. And so really thinking about our norms when it comes to substances. In some areas, we actually heard there's stigma against sober activities. So people that were not using were actually stigmatized against because of that. So, you can't have a beer, what's wrong with you? Like they felt like they didn't fit in because they weren't consuming substances. We also learned participants perceive connections to culturally appropriate treatment as very important. I would say this was probably most highlighted with our American Indian participants in several studies actually, but definitely in this study too, that really the benefit of culturally relevant activities and cultural healing techniques was so powerful in their process of recovery, and really deserves as many resources as we can give them. And just so many really neat stories there. Also, we learned that a reconstruction of social networks from those promoting addiction to those supporting recovery was super important. So in our folks that we worked with and interviewed with in rural communities, they really struggled with moving from a using group of people to a group of people that were not using. And they had a really hard time sort of breaking into social circles that were more healthy for them because of stigma. So they were still seen as a substance user. They, of course, there was many things shared. They had a hard time getting a job. They experienced stigma, which Catherine's going to talk about later, in so many areas of their life. But really, we know those social connections are so important in maintaining recovery, and yet it was something that was very difficult to achieve. We also had some feedback from treatment court participants in St. Louis and Carlton counties. This, again, we learned that negative attitudes of the community and public organizations are a huge barrier to recovery and really made people afraid of sharing their stories, which, again, we shared. Sharing stories is one of the most powerful tools we have in changing our community norms, and yet stigma prevents people from doing that. We also learned that inviting community members to witness and celebrate the success of these participants and to observe how they're being supported really allowed those participants to engage more fully in the community. So it was kind of a community level change where when our local businesses saw, look, these folks are getting better, like look how hard they're working, they are really doing a great job, maybe I will hire them, maybe I won't discriminate against them anymore, maybe I will offer them housing that I have that I'd previously turned them away from. And a few studies we did focused on healthcare provider perceptions on substance use. And we really learned, again, not surprisingly, we did not ask questions about stigma, I don't think, in any of these studies, but stigma came up nonetheless. Really, in this particular survey, there were just outright comments by healthcare providers that were very stigmatizing and really labeled people with a substance use disorder as a very undesirable group to work with. There were concerns with prescribing to them, opioids in particular, I think, and perhaps wanting to not prescribe medication-assisted treatment to them. They were worried about liability. There were some that denied there was an opioid crisis entirely. And we really also heard that there's sometimes poor communication between professions, which we as, if there's any health professional educators in this group today, this is something that we can do something about. So I'm going to turn it over to Catherine now. So these studies that I've shared right now are kind of leading up to the bigger project that Catherine's been working with us on, and we're so thankful for her help. She's just done an excellent job working with our team, which includes Recovery Alliance Duluth, Beth Elstead, and then folks from public health and different facets of the community and the university. So Catherine, I'm going to turn it over to you.
Thank you, Dr. Palombi. So today I'll be sharing results from our needs assessment of the Northeast Minnesota recovery community. The motivation behind this project was the lack of prevention, treatment, and recovery resources available for people living with substance use disorders in rural Northeast Minnesota. And expansion and optimization of resources in this region should be informed by community needs. We developed a needs assessment survey from a tool called Life in Recovery survey from the organization Faces and Voices of Recovery. And we asked questions about demographics, substance use patterns, utilization of treatment and recovery services, perceptions of stigma, social and financial needs. And the survey was distributed largely online due to COVID, but if some copies were distributed at a few recovery events. And eligible participants were 18 years or older and identified as being in recovery. And we targeted the survey towards people living in Northeast Minnesota, but it was distributed more widely than expected. And we got about 600 total responses from across the US, 280 of which were from this Northeast Minnesota 7-county region that I've highlighted in the salmon. And you can see here that most responses came from the St. Louis County, which does happen to have a larger population than the remaining 6 counties combined. And so today I'll be discussing results from this needs assessment as they relate to experiences of stigma. And as we've been hearing about, substance use disorder is a stigmatized illness in our society and is a major barrier to recovery and well-being. And we aim to identify realms for anti-stigma interventions and to inform the optimization of our treatment and recovery services. Next slide, please. So the two main questions we had here were, one, where were people experiencing substance use stigma, as in which realms of society? And two, who has the worst experiences? And as I'll discuss in a bit, individuals may also experience stigma due to other intersecting identities, such as race, sexual orientation, incarceration history, and the type of substance that's being used. And we were curious to know if certain of these intersecting identities shaped experiences of substance use stigma. And an important note here, when I talk about stigma today, I'm referring only to enacted stigma or perceived experiences of discrimination. Next slide, please. So to get to our first question, in what realms of society are people experiencing substance use in stigma in rural Northeast Minnesota? Next slide. We found that people experience substance use stigma in multiple domains of society, and these can be grouped into 4 main areas. And the first is within the community. For example, 40% of respondents said that they experienced stigma or discrimination during interactions with family or friends. And the second is in career or educational pursuits. For example, over half of respondents said they experienced stigma while applying for jobs. The third is while seeking health and recovery services. 34% of respondents experienced stigma when seeking mental health treatment and 31% when seeking medical treatment. And the fourth is while obtaining basic needs and services like housing or government aid. For example, close to a quarter of respondents said they experienced stigma related to their substance use while seeking housing. And what was really concerning is that the majority of respondents, 75%, identified experiences of stigma across multiple of these domains in society. And that's what this Venn diagram back here is meant to represent. Close to a quarter of respondents identified experiences of stigma across all 4 domains. And that means, for example, I'm experiencing stigma from my family or at church, but also from my doctor and also from employers and also from the landlord. And it's coming from all directions. And you can see how that would have really negative consequences for mental health, finding social support, meeting income and housing needs, things like that. So these results indicate the need for an interconnected or interdisciplinary response to substance use stigma. Next slide, please. On to question 2, who has it worse? This turned out to be a very broad question, so we focused on substance use stigma in medical settings. And why? Because substance use stigma coming from health professionals is of major concern, as healthcare providers across a variety of disciplines serve a really important role in substance use disorder treatment and recovery, especially in rural areas like in northeast Minnesota, where the existing services are quite limited. And unfortunately, it's not uncommon for healthcare providers to hold negative attitudes towards patients with substance use disorder or lack appropriate training to work with this population. And this can limit their ability to form the effective collaborative relationship with their patient that's needed, and it could deter their patients from seeking needed medical care. And people from substance use disorder also could be experiencing discrimination from healthcare providers due to other intersecting identities like race, ethnicity, or gender. Previous studies have shown that people of color and women tend to experience worse implicit bias from healthcare providers, which is associated with the lower quality of care. And there's a growing body of literature concerned with describing ways in which intersecting identities impact experiences of substance use stigma, but less work has been done to see how race and gender specifically interact to shape experiences of substance use stigma. So our question of who has it worse was sharpened to is race, gender, or a combination of the two associated with a higher risk of experiencing substance use stigma in medical settings. Next slide, please. So due to sample size limitations, we categorize race as a binary variable. So it was Black, Indigenous, and people of color, BIPOC group versus white, and gender was categorized as cisgender, male, and female. And our results provide evidence of a gender-based disparity in experiences of enacted substance use stigma in medical settings. For both BIPOC and white subgroups, women had a higher risk of experiencing stigma than men. And while we adjusted for healthcare seeking in this model, a possible explanation for this result is that women may have simply used more healthcare than men or used different types of services. But regardless of this, the implication of the results still holds, is that women with a history of substance use disorder are enduring lower quality care for their medical needs. And contrary to our initial hypothesis, people of color had similar risk of experiencing substance use related stigma than white people of the same gender. Furthermore, a more historically privileged group, white women, appeared to have a marginally significant excess risk of stigma on the additive scale due to their combination of race and gender. And there's a few possible explanations for these findings. First is that classifying all people of color into one BIPOC group likely averaged out important race-gender differences. And second, we were measuring perceived stigma, perceived discrimination. So there may have been differences in the way that stigma is recognized and reported between white and BIPOC individuals. And we do see evidence from other studies that, that suggest that white individuals, despite being the non-marginalized group, may perceive or report more discrimination than people of color. So differences in the way that these experiences are perceived and processed on the individual level could have introduced some reporting bias in these results. Next slide, please. And we also did a sensitivity analysis with the full Minnesota here. You can see the sample size is now like 451 instead of like 250, so that we'd have a bit more power to look at race on a more granular level. And here we classified race as Black, American, Native American, additional race, ethnicity, and white. And the main takeaway from this analysis is that there appear to be differences in risk of stigma across different race gender subgroups. So white and Native American women had a higher risk of experiencing stigma than white men. And interestingly, additional race and ethnicity men, which is comprised mainly of individuals who identify as Latino, had a higher risk of experiencing stigma than white men. And this implies that programming efforts would really benefit from targeting medical providers who work with these specific communities. And in conclusion, despite some methodological limitations, the results here the results that I've shown here advance our understanding of who is at greatest risk of stigma in medical settings. And quality of care must be improved for women and racial minority groups living with substance use disorders. Targeted interventions for these groups will help us make progress towards eliminating substance use related health inequities in rural areas of the US. Next slide, please. And I'd like to end with just some suggestions from the recovery community from this needs assessment for fighting substance use stigma. The first one that came out was education. People said, until everyone is educated on substance use disorders, the stigma will never change. Get more information out to the public so we don't feel like such outcasts. I was afraid of what people would say about me until I found others I could connect to. The next one is to change the language, as we've talked about already. Please don't call me a junkie. Don't let me hear the name alcoholic. And the third is to provide empathic support. It was really hard to ask for help when people you are asking or trying to ask have a preconceived opinion about what it means to be an addict. And there were times when I was made to feel less than and not worth their time, even once I got clean. And with that, I'll hand the floor back to Laura.
So thank you, Catherine. Catherine did just such so I am so thankful that she's a part of our team. So, you know, we're going to leave some time for questions. So definitely we welcome your questions and love to chat about what you think is interesting about this. But really want to just kind of leave with some things to think about. So again, we heard we heard from the community, we heard from all the things that we've done, all the topics we presented on. That really getting educated is the best thing you can do. Recognizing substance use disorder as a medical condition and not a moral failure. In particular, if you are a healthcare professional and if you don't understand how addiction works in the brain, that is something that you should get educated on so that you can understand and really be a better clinician. And I think, again, familiarizing yourself with myth versus fact. There's so many myths out there when it comes to substance use and harm reduction as well, I'll add. We see a lot of stigma around harm reduction, which is really an evidence-based practice that unfortunately a lot of health professionals, because they are not educated, are not supportive of, even though it could be saving people's lives and really reducing things like HIV and hepatitis C, which we are seeing increases in both of those in our state because of the pandemic. In particular, in Duluth, we have a new HIV outbreak that is very concerning. So again, familiarize yourself with myth versus fact. Again, thinking about people in recovery, it's such hard work to be in recovery and to really try to maintain those social relationships and avoid the triggering substances. And so any way that you can support chemical-free community and family events is a wonderful investment. And really thinking about what are your norms when it comes to substance use. I think appreciating the work that it takes to enter and engage in recovery from a substance use disorder. Maybe some of us have a loved one who's been in recovery, so we might understand that, but some of us might not. This is really, really hard work. It's not just taking a pill. There's a lot of work that comes into the healing process. A lot of people with substance use disorders have a history of trauma, you know, things that they've used substances to be able to numb things out. And so really appreciating that there's a lot of inner work that goes into recovery and appreciating that. So remember that nobody chooses a life of addiction. We like to bring this up when we do our trainings too. We do believe everybody wants and values the same things, that just a happy life and spending time with their loved ones, and that no child ever aspires to grow up and become addicted to a substance and have that be their lifestyle. So this is something that we need to support people as they get healthy. And again, every person with a substance use disorder is somebody's loved one and deserves a second chance or a third or a fourth chance. This is something that is kind of frustrating when we you know, through our work in the community. There's a lot of people out there that think, oh, they went to treatment and it failed, so, you know, therefore they're dismissed, kind of like the quote that Catherine shared too. This is a chronic disease state. So if, you know, if somebody had asthma, would we be really upset with them if they had to go to the hospital a few times for their asthma exacerbations? Would we ever deny them their inhaler like we deny people naloxone? So really, especially you healthcare professionals in this webinar, please think about this, not just for you, but how can you have a positive impact on your peers and colleagues? And so we'll leave you with this question here. What action are you taking against substance use stigma in your own profession or life? And if you can't answer this, think about what action could you be taking? So Deb, I think this is where we turn it over to you.
Yeah, yes, thank you. Thank you so much. That was great. Really wonderful presentation, both of you, and much appreciated. So again, if you've got questions, please type them into the Q&A function. If you want to clarify or follow up, feel free to type again into the Q&A function, and we'll try to get back to you. There will be an evaluation that will be emailed to you after the event. It'll also appear as the window, your browser window is closing after the event. So if you could please fill that out, that's very helpful for us in terms of our programming. Here is the information about folks who need interprofessional education credit. That's for, as you can see, students in the listed programs on the slide: allied health, dentistry, medicine, nursing, pharmacy, public health, related programs. If you email the center, you can get the reflection that you need to fill out in order to get that credit. And the recording of this event will be available as soon as we can get it available on the center's website afterwards. So if you want to see it again or use it as a resource in your courses or whatever, that would be great. Let me turn to questions at this point. There are a few things in the Q&A already, and I know I have questions as well. So, but let's start with folks' questions from the audience. And we'll begin with a really important point and question here about sort of access, which I think they're really interesting questions about how stigma intersects with access. The participant says cultural residential programs run by the tribes will not accept persons who are committed for chemical dependency. I've tried numerous times to get someone placed, but they continue to have a prejudiced view of committed persons. It's very frustrating. I wonder if you can sort of comment on that intersection of stigma and access, or lack of access, sort of the impact of stigma on lack of access.
I think that's a tough one. And I know there's some experts in the audience from the community, so I might just pause for a moment to see if one of them who I think has more life experience in this particular issue, if they want to chime in. Okay, no volunteers, that's okay. So yeah, looking broadly at stigma and lack of access, I mean, this is definitely why we're doing the work that we're doing, I think, and why we try to do the education that we can. And I think there's just so many different levels of stigma that it's hard to even, it's just a word, but it's a huge concept, and how it manifests itself is different depending on every level and every different component, I would say. So yeah, I'm not sure I'm not sure how to best answer that, but I agree. Like, I think all of our biggest, if we really want to make a big difference, and we heard this from our participants in this research study, if we really want to make a big difference in improving outcomes for people with substance use disorder, our number one effort should be in stigma, addressing stigma, and educating our health professionals better, and advocating for people with substance use disorders among all these different levels. So unfortunately, I don't have a much better answer than that. Probably doesn't answer the question.
No, I think it's helpful. I mean, clearly I mean, you started with the statistic that only 11% of people are able to access treatment, which is appalling. And, you know, clearly there are huge ethics issues there. And you may not be able to exactly pinpoint the degree to which stigma is the barrier to access, but clearly, especially given the question that's being raised by this audience member, there is a connection, right, between stigma and lack of access in ways that are really structural, right? Not just I'm afraid to access treatment, but treatment is not available to me. Yeah. Let's go to the next question. Can you expand on mental health and you know, stigma as it relates to other patient populations other than substance use disorder?
Yeah, I mean, I think, and probably we could have maybe emphasized this more. I would say, even though, so the feedback that we got regarding mental health and substance use, it's very hard to pull those apart. I would say, like all of the projects that I've done, this substance use and the mental health conditions they're this kind of the same. I mean, they're not the same, but they kind of are in the community members, what they're sharing about. When the community members share with us, it's not just, here's my substance use disorder and here's the mental health condition I'm struggling with. It's all of it together. And although some of our events forum we did once with the Mille Lacs Band, when we do mental health forums and we hear from the community members, they still bring up substance use. And when we do substance use forums, we always hear about mental health. So I would say they're kind of inextricably intertwined. So it's kind of tricky to pull them apart, but I would say the mental health stigma goes right along with the substance use stigma. Catherine, I'm not sure if our study, can you think of anything specific from the RAD project that would answer this question?
I didn't dig too deeply into the way that like a mental health, a history of mental illness, like intersected in all of this. But I did see like a fairly high proportion of individuals and identified a history of mental illness. And I don't know if this is related, but there was kind of an interesting disparity between, let's see, where is this? Like a history. So 11% of the respondents in the like Northeast Minnesota group, 11% of white women said they had a history of mental illness, but 45% of BIPOC men said they had a history of mental illness. And like overall, it was like 30%. So you see these pretty big disparities between different race, gender subgroups. So I don't know if that helps or is interesting.
It seems really interesting to me. And I mean, this is one of the things that I was thinking about when you were presenting the race data, and the data about sort of stigma and how it pervades across domains, right? And so one of the things that was striking to me, and I don't know if you have data to comment on this or if you can just comment on it in general, is the questions about sort of what are the downstream effects in terms of health disparities and how does the intersectionality work there? Because it strikes me that if stigma is affecting your housing and your job opportunities and so on for substance use disorder, then that's going to have downstream effects on your health. It's going to get tied to sort of this whole conversation about social determinants of health, right? But then when you think about racialized populations and the ways in which they already experience, health disparities because of systematic racism, institutionalized racism, the intersection of the effects of the stigma around their substance use disorder and all the rest of the structures that they have to contend with, and that impact health outcomes. it's super troubling.
Yeah, and I think that was one of the sort of the motivations for the specific study that I did, to see like certain groups who are already experience implicit bias in healthcare settings. Do they have it worse because they also have a substance use disorder? And something Laura and I have been talking about is like how this probably comes across in the survey and the responses that we're getting, like how are people perceiving this sort of bias or discrimination due to their substance use disorder, if they're just like, if this is kind of something they encounter on a day-to-day basis, like can you really pry that apart, like institutional racism versus like structural barriers to having getting recovery and that kind of treatment.
So let's go to the next question. This questioner says, responding to the statement by one of your participants, I don't want to hear the word alcoholic. In this participant's experience, both in person and listening to the media, many people have been sober for a long time or who grew up in families with patterns of substance use the word alcoholic all the time. I wonder if you could address those issues around language in a little bit more depth.
Yeah, I think I can take this one. So there's many different paths to recovery. And so there's, and really depending on, what area you live in, in northern Minnesota, rural Minnesota, there's fewer options for recovery. So 12-step programs, for example, might be predominant because that's what's available. And then as you get, closer to Duluth, which is a little bit bigger, there's other options too. We have Celebrate Recovery. Oh, there's another one too. But so different recovery paths have different ways of looking at substance use disorders. So in some of those paths, they might start a meeting with, hi, my name is Laura and I'm an alcoholic. And then that's a part of how they do their recovery path, is that they remind themselves that they are an alcoholic and they're taking things day by day, and that's their label for themselves, right? And that's their recovery path, which we have to respect. So if they're using that word and that's a part of their recovery, then I'm going to respect that. There's other recovery paths where there's the thought that we're less defined by our substance use disorder and more defined by who we are as a person and what we're doing right now. And so really what it comes down to is there's different paths to recovery. And in those different paths, there's different ways of like labeling substance use disorder. So our job as community members, and maybe if we have a loved one and they tell us, you can call me an alcoholic, that's what I am, that's fine. But for me, I am not, because I'm not in recovery, and because I'm an ally and a supporter, I use the term substance use disorder because I don't know if this person in recovery, do they call themselves an addict? Because that's another thing, like part of some recovery circles, my name is Laura and I'm an addict. That's a part of their identity in their recovery. But in other recovery circles, that's not the case. Like there's not that sort of, and I think Beth's on the call. I can let Beth chime in. She'll do a much better job with this question. But long story short, I think that for us as allies and being supportive people, the most respectful thing we can do is use terms like substance use disorder, alcohol use disorder, opioid use disorder, without knowing that person's particular path and whether or not they're even in recovery, because we know that those are clinical terms that do not carry the stigma that other words like addict and alcoholic do. So I don't know, Beth, if you're on and if you want to take that question.
I'm checking here to see if there's a
Beth Elstead. Sorry to call on you. If she's not here, that's okay. But yeah, I think that's kind of just a best practice, I would say, for us as supportive community members, is to use the most kind and respectful language we can, even though the media doesn't.
So maybe the most sort of neutral language in a sense, until somebody has, yeah.
Yep. Yeah. and just respect that each person has different preferences.
So the next questioner says, in the process of treating patients, how do you balance the need to tell the person the truth of their condition with the ongoing need to be sensitive to stigma? How do you sort of walk that path? I think this relates to the language question in a way as well.
Mm-hmm. I think that's a good question. So I guess, and I want to say like, I am a pharmacist, but I no longer work in a community pharmacy. What I do largely now is I work in collaborations with public health and rural and tribal communities. And so I want to preface this by saying that I am not a clinician, as other people maybe are. And again, we open this up we want this to be a discussion because we know there's a lot of expertise in this room right now with us in this Zoom room. So I think what I've seen through my work with Carlton County Drug Court and other drug courts too, there is a process of, I would say, telling the person the truth of their condition. I think that actually needs to be something that they realize on their own. And so I think we really struggle with, it would be hard to have a conversation about stigma unless somebody actually realized that they have a problem and they had a desire to, seek treatment. So if somebody comes into treatment and they don't acknowledge that they have the problem, I think that's tough. Like, we're probably not going to tell them, like, it needs to be something that they kind of come up with on their own. And then, and balancing that with the ongoing need to be sensitive to stigma, I think, I would say when we're working with people who are going through treatment and recovery, I think it's all about like just being a kind, loving person. I mean, for lack of a better word, like we just need to support people where they're at. So if people are still using, they don't need our judgment. And us telling them that they have a problem is probably not going to help. They need to realize that there's a problem that they want to change on their own. There's ways that we can have conversations, motivational interviewing, for example, where we elicit change from them. And generally that's what's helpful is when it's guided by that person's desire rather than somebody telling them that. So, but either way, so I think meeting people where they're at, if they're currently using substances, just being a kind person to them, being there for them if they decide that they do want to get help, like knowing that you're not going to be a judgmental person, that you care about them no matter what. And then as they go through their treatment and their recovery, again, being that same sort of person who is there and supportive and not judging, and not expecting perfection. I think if we all could do that, we would have a much better world, and we would have a much, much smaller substance use crisis if we were all just kind human beings to people with substance use disorders. That's my thought. But, the clinicians in the group, feel free to chime in, or Catherine, I don't know if you have thoughts on this too.
I see that Carrie Hager has put in the chat, you can speak truth without stigmatizing by being non-judgmental. And as you were saying, Laura, speaking with love, empathy, and kindness. So let's go to the next question. What kind of differences do you observe, if any, between different age groups in terms of stigma? Did your research look at age?
Well, we didn't have the preteen or teen adolescent subgroup because ours, we focused on individuals 18 years and up. But Catherine, can you comment on that one?
Yeah, I guess I actually didn't look as much at age as years of active substance use and age of first use. And definitely there is like a trend where people who start using substances when they're in adolescence, so less than 18 years, seem to like experience more stigma, and then it kind of goes down, so that people who are like full-fledged adults, when they start using stigma, report relatively less stigma. And I haven't done like a full analysis of that, but that's sort of the trend that I noticed in our data.
Thanks. The next questioner asks, is it accurate to say that discrimination is an outcome of stigma?
I would say yes. I think there's a really good article called Stop Talking Dirty. It's a really, the author's, I think, John Kelly, his last name is Kelly. It's a really quick read, really excellent, and it really talks about how stigma and the language we use leads to poor outcomes, and it kind of lays that out. So looks like I can type an answer here. So the name of the article is Stop Talking Dirty. It kind of just pulls it all together in a really quick, readable way.
Thank you. The next question is a clarifying one. In the slide comparing the stick figures of stigmatized and non-stigmatized groups that was early in the presentation, can you clarify the things listed as experienced by the non-stigmatized groups? Are those things that happen to them or things that they participate in?
Yeah, that's like the sort of the way they are participating in stigma. I guess it's I don't know if I'm describing this like really well, but for someone in the non-stigmatized group, they might hold a negative affect towards someone in the stigmatized group. They might have negative beliefs about that person or stereotypes, and then they like maybe act in a sort of discriminatory way. So that's something that that's how they participate in the stigma. That's the mechanism. And that kind of leads to the things that we see, like social avoidance and housing discrimination. Does that answer the question?
Yes, thank you. The next question says, thank you so much for your presentation. It's such needed and important work. And it asks if you have at least initial reflections on what more culturally and gender attentive treatment options would look like. Questioner says, for example, I've heard stories of Narcotics Anonymous 12 steps being more difficult for marginalized groups, being told you have to accept that you're powerless when you already may not feel you've ever had much social power in your life. And the questioner is just curious if this resonates with what you've heard from people in your research.
This is a great question. I do think, so I can, boy, you know, and I feel like such an amateur in answering this, but I'll do my best. So I think when it comes to what do more culturally attentive treatment options look like, I think, you know, I'm most familiar with American Indian cultural treatments, and those have been just really phenomenal. Like I just, seeing the successes of people that are engaging in those programs is just amazing. And I'm just blown away by their success. And so I think that definitely, but they're not for everybody. So there are some people that maybe identify with a cultural group, but for whatever reason, they don't want to engage in those practices. So I think like the biggest point is that one size doesn't fit all. And really there are, and I think it's tough because, you know, and maybe the COVID pandemic has made this easier because now there's a lot more online, but it's tough when you feel limited to what's in your area geographically. You know, if there's only one group that meets, that feels really tough. We do have people that drive to Duluth because there's programs here that aren't in their area. But I would say, just looking around, you know, online, you can find some different recovery groups, and a lot of recovery groups are on Facebook now. So that's a good way to, you know, even if you don't have that particular cultural group in your geographic area, you can find a Facebook group that is a supportive group for that identity. There's a lot of them out there, and there's a lot of groups now that are meeting online that never used to be. So even though the COVID-19 pandemic has been very, very tough on people with a substance use disorder and people in recovery, because they are not able to have that, or at least hadn't for a while been able to do that face-to-face interaction that is so helpful. There are some like more creative and positive things that have come from this that are online. So I guess my thing that I would share, and again, not being an expert and there's definitely experts in the recovery process, but I would say just looking around to see what other programs are out there and not feeling like you have to stick with one particular program if it's not the best thing for you. That's what I've learned from Beth at Recovery Alliance Duluth, that everybody's path is different. Yeah, there are treatment programs for women that are pretty successful, because a lot of times women, I think the evidence tells us too, like we were separating men and women in treatment court because we found that the women were more comfortable when they reported to the judge separate from the men. There were just, fewer distractions. They just felt a lot better. And so there's different ways that we can kind of tailor our recovery work to meet these needs. So.
Thanks. Next question. Suburban high schools indicate that 50% of their students currently use pot for mental health help, not just to get high. How has legalizing pot in other states helped or hurt sobriety, etc.? Do you have an idea about the impact of legalization of pot on these sorts of issues?
I'm definitely not an expert in this area, but what I have heard has not been particularly positive, and that there's a lot more teen mental health issues that have surfaced as a result of this. So even though the teens are probably using it for mental health, that there is a risk for psychosis that I've seen. But again, I don't know if that's just me speaking with other researchers. I don't know if that's actually something that is widespread or not. So I will let somebody else from the audience who has more experience answer that, or Catherine, I don't know if you've been following that.
So if folks have information about that, you can put that in the chat. That would be great.
Yep.
Next question. Have you communities as well? Questioner says, from interviews they've been a part of with those with substance use disorders, they've talked about struggling with the heavy stigma within the treatment community, especially around medications like Suboxone. Curious if you've heard similar sorts of things.
Yep, we did. So I'll let Catherine speak as to whether or not we saw that in the Recovery Alliance Duluth survey, but when we did our focus groups, they were done all across northeastern Minnesota, and there is definitely stigma towards medication-assisted treatment or medications for opioid use disorder. There's a lot of stigma towards methadone, and I think some of that is a result of some methadone treatment facilities that weren't necessarily the most responsible with how they ran their procedures. And so because of that, there's a bad reputation, very bad reputation in some areas of the state, and people that absolutely will not consider methadone, and that thought is within the healthcare professional community as well. I would say I also, that it's not just methadone, it also is Suboxone, where we even heard from, we had a focus group, and I remember this so well, where somebody spoke up and she said, you know what, I usually don't share this because people look down on me, but I had to use Suboxone to get off of opioids. I was using, I can't remember what her dose was, but I was using this many milligrams of opioids a day, and there was no way that I could get off of that without using Suboxone. And I don't share that because people think that I'm weaker, and they think that, abstinence is the only way, but Suboxone was the only way that I could do it. And so there was significant stigma towards the use of MAT, and that's been a huge barrier. We've had people in treatment court that would be great candidates for MAT or MOUD, whatever acronym you use, that because of stigma, like within the recovery community that they were a part of, or maybe it's just their social circle, they felt like it would be a weakness for them to try using that. Or there's the thought that you're just substituting one drug for another. So why don't you just get off all drugs instead of turning to another drug? And there's also the thought that came out in focus groups that medications to treat opioid use disorder are just a government conspiracy, so that the government can make money off of your substance use disorder rather than the dealers on the street. So yes, we have seen stigma when it comes to medications like Suboxone and methadone.
So I'm going to ask a sort of related question. There's another question in the chat here about medication-assisted therapy. The person says, I was very much struck by the fact that 34% of respondents said that they experienced substance use disorder stigma when accessing mental health treatment. One thing to add to the conversation is that many intensive mental health treatment programs don't accept people who are on medication-assisted therapies or who are still using. Has that been your sense of it too, Lauren? And do you want to comment on that?
You know, and this is where because I'm no longer on the Carlton County Treatment Court team, I feel a little removed from this. So, so I've had some other great opportunities. You know, I loved working on the treatment court team and having that more clinical role, but I have some other good opportunities now that have pulled me away from that. So I don't know that I can answer this very well, but I really appreciate the comment and Kate sharing this, because I think this is helpful for all of us to be aware of when we think about so somebody who is on medication-assisted therapy, you know, they're trying to get their life on track, and they realized, you know, like, oh, my opioid use disorder probably results from an underlying mental health condition. So I think I'm going to get help for that. Oh, well, I guess I can't because the mental health treatment program won't accept me. Like, we even have people, I mean, we're still struggling to get people who, like, treatment courts, not all of them are supportive, really surprisingly, or even in jails. Like, we've had people in treatment court who were stable, you know, they had to go into jail for a short period of time, maybe because they broke some, you know, probation, they had a probation violation. So they're supposed to go to jail for 2 days, but the jail doesn't allow a medication-assisted treatment either. So now when we do what we're supposed to do as a treatment court team by giving them, you know, this short jail stay, which evidence-based tells us that that's the best thing to get them back on track. Now we're going to jeopardize their recovery because they can't get their medications for opioid use disorder. So there, again, we talked about like the different systems levels of stigma. It's not just individuals, it's systems, but individuals can make an impact on systems.
Thanks. The next question, Mark Thomas, who I'm saying because he's introducing himself in the question, from the Medical Discovery Team on Addiction, says, wonderful talk. What kinds of educational tools do we have available to combat stigma, and what would be most useful in terms of how we get this out to people?
Yeah, I think, like you said, Mark, the neuroscience of addiction, I think when it comes to healthcare professionals, I think that's where we've got to start focusing more time and energy and really getting people to understand the neuroscience of addiction, to really eliminate that belief that substance use disorders are a moral failure. And this is for all healthcare professionals. We will have so many more prescribers of medications for opioid use disorder. We will have pharmacists that are more supportive and hopefully can bridge that next gap to supporting other evidence-based strategies such as harm reduction. But I think that's a huge part of it is if you think that it's a moral failure, you don't understand the neuroscience, then you kind of just, we all fall flat. And that's, if we recognize the neuroscience of addiction, like we do how diabetes works, that would be a great start. I think, and I think, you know, a lot of us maybe are healthcare professional folks who have an impact on students, or maybe we are educators that have an impact on students. And so again, if we're not familiar with this ourselves, we've got to start here, and then we've got to start advocating, you know, and it's tough to be the person that corrects a colleague or a peer. But we've got to start not being okay with it. Creating policies and procedures and deciding as organizations or facilities that we're not going to allow this anymore. And maybe have some peer, we know that actually with physicians that the impact of peers' opinions is actually pretty powerful. So again, maybe getting those physician champions out there a little bit more, the pharmacist champions out there, whatever that might be, is that peer support or even peer pressure is something that we could leverage in this case when it comes to our healthcare providers.
Thanks for that suggestion. There are so many open questions left in the Q&A function, and we're already a little bit over time. So I'm afraid I'm going to have to call it at this point. And I'm sorry for all the folks who did not get their questions answered. I really want to thank both Catherine and Laura for presenting today. Obviously, given how active the conversation has been and how many people still want to get in, it's just really clear how important these issues are, and how valuable this conversation has been, and you know, sort of the significance of your research. So I really appreciate your taking the time to be with us today. And I also want to call people's attention to the next ethics grand rounds, which will be at the end of the month, on the 28th, I believe. Yes, there it is. Zach Berger from the Berman Institute of Bioethics and the School of Public Health at Johns Hopkins is going to do a presentation on ethics and equity issues around long COVID. And he's going to present to us an alternative model of delivering health in the US to try to deal with the long COVID issues. So hope to see everybody there. And again, thanks very much to Laura and to Catherine for the conversation today. And thanks to everyone for joining us.